Hello.
Okay, you can continue.
Question 6. A 6-year-old lady with symptoms of abdominal swelling, leg swelling, atopnia, and cough productive of brownish sputum. On examination, she has an irregular pulse, raised JVP, pansystolic murmur, loudest at the apex, and radiating to the left axilla, and bibasal coarse crepitations. History of sore throat infection in childhood. The question is, what is your diagnosis? What investigations would you do? How would you manage, and what are the prognostic factors? Now, my diagnosis for this case is heart failure secondary to rheumatic heart disease, preceded by atrial fibrillation and chest infection. What investigation will you do? I will want to do a chest X-ray, which will view cardiomegaly, features of pulmonary congestions, upper lobe diversions. It also may review consolidation. ECG will review a regular reading with no discernible P wave. There will also be an left ventricular enlargement with strength pattern. The echo will be very important in this case, to quantitate the severity of mitral insufficiency, which of course may show a pansystolic jet length, jet of greater than or equal to 2 centimeters, with a peak velocity of greater than or equal to 3 meters per second, at least in 2 views. It's also important to assess the left ventricular function, able to classify especially into heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. It also be very important to, in case of any intracardiac thrombus, especially the transesophageal will be very important in this case, the case where the thrombus located at the left atrial appendage. You also may review chamber dilatations, caudal elongations. It's also anterior leaflet tip prolapse may be present. Other investigations include the serum erythrolysin titer, at least for possible seroconversions. Full blood counts will show leukocytosis or neutrophilia. Sputum MCS may detect pathogens and this will help to guide the choice of antibiotics. ESR may be elevated, serious protein may be normal or elevated. Cardiac markers like B-natriuretic peptide may be elevated also. Cardiac troponin I, very important also to exclude any permanent myocardial damage. EUCR also important in this case for may detect electrolyte imbalance like hyponatremia, which of course may be a prognostic factor. It's also important to assess the renal status. PTI now, of course, in as a baseline, also in view of promoting this patient on anticoagulation because of the atrial fibrillation. How would you manage? So management of this patient include secondary antibiotic prophylaxis with the use of IM benzathine penicillin given at 1.2 million units every 4 weeks. Then also important to manage heart failure with guideline-directed medical therapy. Loop diuretics is important because of the fluid overload. Also, atrial fibrillation will be managed. It can be at least to achieve either a rhythm or rate control, either pharmacological with beta blockers. Also, we can also use amiodarone for pharmacological conversion. Then patient may also benefit from catheter ablation. Anticoagulation for stroke prevention with the use of oral vitamin K antagonist or vitamin factor 10 inhibitors. Patients also have to be managed, treated for the coexisting infections with antibiotics. Can also use microlife pneumonia. Of course, in case of because of the mitral incompetence, patient also benefit from mitral valve repair. What are the factors? Female gender has been identified as a prognostic factor. Younger age, like our patient 36, also a prognostic factor. A degree of cardiac valvular damage is a prognostic factor. Also, left ventricular function, like we have a reduced ejection fraction, also a prognostic factor. Recurrent acute rheumatic fever attack also has been identified as a prognostic factor. Now, that's the end of the question. Now, I want to look at a review of rheumatic heart disease using this outline from introduction up to the conclusion. Rheumatic heart disease is a complication of acute rheumatic fever, that remains the leading cardiovascular disease among children and young adults in low and middle income countries. It was actually common in all countries until the early 20th century, when incidents began to decline in industrialized nations. It was attributed to improved living conditions, as there was less crowded housing and better hygiene, which led to a reduced transmission of group A streptococcus. Also, introduction of antibiotics and improved system of medcare also have contributed to this success. The global burden of medical disease continues to be significant. Up to 40 million cases was estimated globally in 2017, with highest prevalence found in Oceania, South Asia, and also in our own region. Prevalence range from 3.4 cases per 100,000 in non-endemic, and up to over 1,000 in cases in endemic areas. Data on rheumatic heart disease related morbidity and mortality are less robust, but the estimate is at least over up to 260,000 to 300,000 deaths per year. A global registry of 3,200 rheumatic heart disease cases from 14 lower to mid-income countries revealed that most patients with rheumatic heart disease are young, like Nigeria's patients. They're also female, up to 6%. It presents mostly in moderate to severe multivalvular disease, complicated by congestive heart failure. In 33%, also pulmonary hypertension, even atrial fibrillation, like we've seen in our index case, and also in 7% of cases they may present a stroke. The World Heart Federation actually targets to reduce the burden of rheumatic heart disease by 25% at least by next year. So let's look at the history, the natural history of rheumatic heart disease. Acute rheumatic fever, clinical or subclinical, actually may causes pancarditis. And over the years, there has been a transmission. This transits from rheumatic carditis to rheumatic heart disease, leading to progressive valvular disease, which commonly occurs in the years after one or more episodes. The acute rheumatic fever recurrence is said to be highest in the first year after the initial acute rheumatic fever episode, but low-level risk persists for more than 10 years. Progressive to rheumatic disease was also said to be highest in the first year, almost 10 times higher than acute rheumatic fever recurrence, according to a study in Australia by Conlon et al. In 2017. This actually shows the progression of these conditions to be either from asymptomatic to symptomatic acute heart disease. In asymptomatic, when they actually test them with echocardiography, that may be suggestive of heart disease. It progresses to subclinical definitive rheumatic disease where there may be no murmur, then to present to progress to clinical definitive rheumatic disease where patient may detect murmur, but in this case, patient is still asymptomatic. Then it will progress to symptomatic rheumatic disease up to where you present with complications, and if not handled properly, it may lead to death. These are the clinical features of rheumatic disease. During acute rheumatic fever, rheumatic carditis can manifest either as pancreatitis or and rheumatic disease typically affects the left-sided valves, mostly the mitral valve. Disease occurs in about 2% of cases, and right-sided valve involvement is said to be rare. The cardiac lesions that may be seen are the mitral annular dilatation, anterior leaflet prolapse with varying degrees of mitral regurgitation. Over time, chronic inflammation may result in effusion, which of course may result in involvement of the mitral valve apparatus, resulting in mitral stenosis. Features of heart failure, like progressive dyspnea, which apnea, and other features of heart failure. This patient may present with other features of heart failure. Now, this picture is just to show the rheumatic involvement of the mitral valves, the mitral stenosis, and regurgitation. You can see how thickened this valve is. I don't know if you see my cursor. And then also the severe regurgitation hitting almost the roof of the left atrium. This actually shows the picture on the left shows the common acoustic appearance in mostly seen in mitral stenosis. On the left, that's the the short axis view showing the almost the fish mouth appearance. You see how much thickening the valve is. The C picture just the Doppler spectrum of the mitral stenosis. Look at the diagnosis of how do you diagnose this patient? Look at the history. These are the specific questions that have been that found to be useful in assessing this patient. We want to assess the socioeconomic background, which of course, which is very significant in the diagnostic implication. Also, you want to assess the also helpful in the treatment, and also to know how access the patient may get to care. Also, want to assess the primary care, looking at the previous history of rheumatic fever, the proportion of the patient monitoring this history is actually said to be related to the diligence of the part on the part of the clinicians, and also important to document this in case of discontinuation of medicinal prophylaxis, because most patients, they may be they have not actually have this exposure, or they're important to get this history in order to know whether you have to continue or discontinue the antibiotic prophylaxis. They also want to assess the current symptoms, especially presenting heart failure symptoms. The functional status of this patient is also very important. You want to assess the ascertain the impact of this disease on the livelihood of patient of this patient. Then the patient understanding of this disease is also very important. Also because we want to assess, because of course the patient's knowledge of this problem is important, because we want to at least patient has to adhere to follow up, and also on the medication, especially if they have a good understanding. Then previous hospitalization and specific complications is also important in assessing this patient medications and compliance, and also reproductive history. For patients that have like our index patient, it's so important to assess the previous pregnancies or any contraception, also to assess the patient understanding of the impact of pregnancy on heart disease. Also, family history of rheumatic disease also may have to be ascertained. The physical examinations also to at least was protect for murmurs, and also have to assess the signs and symptoms, signs of heart failure. Then also important to note features of common triggers of rheumatic heart disease, which include pregnancy, acute heart failures, patients may have atrial fibrillation, or features of effective endocarditis. Now, in ECG, like I said earlier, of course, we review left atrial enlargement or left ventricular enlargement strain. It may show atrial fibrillation, like by patient. Then chest X-ray will review cardiomegaly and signs of pulmonary congestions. Echocardiography is very vital in the establishment of diagnosis of heart disease. It's important to assess the severity of the individual valves affected, chamber enlargement, and also to assess for pulmonary hypertension, and also to useful in the planning surgical or interventional therapy. Now, there are minimal criteria that are available. In 2012, the World Heart Federation published first evidence-based guidelines on echocardiographic heart disease. This actually included minimum criteria that were required to diagnose heart disease, and also to harmonize the diagnosis and the classification. But however, there were actually some identified limitations in this criteria. This included different outcome of echo detected rheumatic heart disease, and also practical challenges in applying this disease, this criteria in a busy clinic setting. Now, in 2023, understanding the natural history of rheumatic heart disease and the risk factors for the progression, the World Heart Federation provided a revised minimum echocardiographic criteria for the definitive diagnosis of rheumatic heart disease. It actually this includes and also on the ground that echocardiography said to be vastly superior to auscultation for detection of rheumatic heart disease. Then this classification also took in consideration the new classification of rheumatic heart disease that was based on the disease progression, and a two-step two-step echo algorithm for active case detection findings through the screening criteria, and for suspected cases, and also complementary criteria for definitive cases. The screening criteria for this case is actually intended to rapidly detect the possible diseases in setting in which rheumatic disease is highly prevalent, and in which the equipment and healthcare providers are limited. But it's actually said to be applicable only in individuals aged less than 20 years, and also can also be used in high volume screening programs. The confirmatory criteria is actually for definitive diagnosis, and they actually involves the use of a 2D imaging, color Doppler, and also continuous wave Doppler echo that aim to discriminate between pathological and physiological changes in the valves. It's also the guideline also consider the management recommendations for any stages of rheumatic heart disease. This is actually just the criteria, have the screening criteria designed principally for non-experts to apply in appropriate setting, and the confirmatory criteria that was designed for experts to use to confirm the diagnosis of rheumatic disease. Now we have the classification into stage A to B to D. The previous classifications that was used in 2012 guidelines, including the borderline, definitive, and latent, are no longer recommended. Also, the weight-based measurement of valvular reputation, and also recommendation for the management of early stage, like I said earlier. Now, these are just the definition of the terms that were used in 2012 guidelines. Now, this just shows the different approach to the management of these conditions, starting from the classifications, starting from screening, the classification, and then also the different stages and recommendations for management of this case. I think we can go through it after we'll get the slide. Then this is just the shows the different level of evidence for different stages of this condition and the approach to the management and duration of the secondary antibiotic prophylaxis. Now, okay, I've said this. This just talking about what I said earlier about the screening criteria. Then, management of rheumatic heart disease is actually registry-based. It's a registry-based care approach, which was actually recommended by WHO as a vital adjunct for the prevention and control of rheumatic heart disease. And its purpose is to ensure optimal clinical care for patients within available resources. And the primary care providers are actually in the maintenance of these formations, one that should be in these registries. Now, the secondary penicillin prophylaxis is the secondary antibiotic prophylaxis. The rationale actually is for those who, with an initial episode of disease, are said to be at higher risk of recurrence.
You need to round up.
Okay, and the recurrent acute rheumatic fever can cause rheumatic heart disease in those whose hearts were not initially affected and can worsen existing rheumatic disease. So treatment of somatic focal infection is not adequate to prevent acute rheumatic fever because asymptomatic can actually trigger acute rheumatic fever. And recurrent ARF can occur even in the setting of adequate treatment. So secondary prevention is said to be a cornerstone of the treatment of rheumatic heart disease. This actually shows the different area where secondary prevention is very important, even from rheumatic fever to rheumatic heart disease. And even when patient actually comes down with fever, important also to commence secondary prophylaxis to prevent premature disability or even death. So penicillin can actually be given in two schedules. Schedule 1 can give it every 4 weeks for most patients, or whereby or 3 weekly for those at risk or those who experience recurrent episodes of acute fever, despite adherence to the 4-week schedule. A New Zealand study actually showed that recurrent ARL is rare in people who are actually adherent to 4-week regimen. And BPG is said to be superior to oral penicillin preventing this condition. The medical treatment, of course, is available for those that cannot afford or have access to surgery. So we want to use diuretics and also for afterload reduction with vasodilators. The digoxin and beta blockers they play a role, will also be important. Then for mitral stenosis, diuretics, the beta blockers to allow greater diastolic feeding. Catheter or surgical intervention, of course, is proving to be effective in this case. AR, you also want to use diuretics, ACI. Then missed mitral valve disease, surgical option is very important. The atrial fibrillation, which is said to be a common complication, it has a higher frequency for patients with missed mitral valve disease, is up to 70%, isolated MS, and also isolated MR is 16%. And these are associated risk factors, in such condition. A complication of this condition can include heart failure, stroke, and even premature death. And treatment, of course, like I said earlier, logical, and also you can use catheter ablation, and also important to anticoagulate this patient for stroke prevention. Endocarditis, which is actually uncommon, but is actually present in severe cases. And it has a high mortality that puts up to 30%. Oral hygiene policy is said to be more than antibiotic prophylaxis for dental surgery. Pregnancy, in most cases, can be a associated factor because of increased cardiac output and decrease in vascular resistance, which this can mask the moderate to severe bad lesions, and it can contribute to maternal mortality within 42 days post-delivery. And all women with rheumatic heart disease have an increased risk of maternal and fetal outcome. And this actually the things that actually that can increase the risk for patients that are pregnant with rheumatic heart disease. As for stenotic lesions, they are usually less tolerated than reconstructive lesions, and occasionally require interventions such as balloon mitral valvuloplasty, and also in most cases may have to terminate the pregnancy. And these are the few recommendations in pregnancy. So in conclusion, the burden of rheumatic disease is still a major public health concern, especially in low middle income countries, and early diagnosis, including echocardiography screening, holds promise for both raising awareness and developing prevention strategies that can increase the need for intervention. And treatment of advanced rheumatic disease remain a major problem with no solution in sight. And medical treatment provide limited symptomatic relief, but advanced rheumatic disease and this complication can only be addressed by interventional association.
Yeah, thank you, Dr. Cassidy, for the presentation. Yeah, thank you very much. Quickly, we invite comments, contributions, questions, please. So while we await that, I'll read out the messages in the chat box. Okay, Dr. Emmanuel, anticoagulation in rheumatic heart disease. You wrote factor 10A inhibitors as part of anticoagulation. The Invictus trial does not support that. Dr. Orogun said that warfarin is preferred for anticoagulation in valvular AF. Also, AF isn't the only cause of irregular pulse rate. So pulse deficit determination will be expected as part of the examination. This picture painted suggests both ventricles are involved. I would love to ask if there are genes implicated in susceptibility to rheumatic heart disease. If it's not been mentioned, okay, I say well done. Then, okay, Dr. Jamila thank you for a lucid presentation. Dr. Momodu said rheumatic heart disease is the underlying cause of a significant proportion of AF in the low and middle income countries, while non-valvular AF is the most common cause of AF in high income countries. Rheumatic heart disease is the delayed sequelae of acute rheumatic fever. While acute rheumatic fever afflicts children between 5 and 15 years of age, rheumatic heart disease is usually diagnosed between 20 and 50 years of age. Yeah, so Dr. Cassidy, the genes implicated in rheumatic heart disease.
Okay, thank you for your comment. I think the gene implicated not very certain. I think it has something with single nucleotide polymorphisms. I think it's linked to that. That implicated in rheumatic heart disease. I'm not very sure.
Okay, Dr. Agu.
Okay, Chief, good morning, sir. Thank you, Chief Cassidy, for the wonderful presentation. I just want to ask two questions. These antibiotics, the usage of these antibiotics, when exactly do you stop? When do you stop? And how do you stop, or do you just give it for life? And then you also said that these lesions are not prominent, in the right-sided valves, that's the tricuspid and pulmonary valves. Why? What's the reason behind that? Is there any reason, or it's just a natural occurrence? Those are my questions. Thank you.
Okay. Well, the antibiotics are actually on the age and also the duration. Most times, say them we can be giving if patient is about 20 or 21 years, so you can give it or sorry, you can give it up to like or up to 10 years, or up to the patient is I think up to 40 years. So I think that is actually the ratio. I can give you up more than 4 years, more than 10 years, or based on the age of the patient. Then the second question, I didn't get that.
Okay, my second question is why we said
It's about the
lesion,
right heart valve. So
right heart valves. You said the lesions are not common, the right-sided valve. So is there any reason for that? I don't know if I'm audible.
Yeah, you are,
Can you hear me?
audible.
Okay, so
Can
let me
you
just
hear,
repeat let me repeat the
Dr.
question.
hello.
Let me repeat the question. I said, you said the lesions, that's the rheumatic diseases, occurs more on the left-sided valves, that's the mitral and aortic valve, right? And they're very uncommon.
Okay.
Those lesions are uncommon,
Yes.
the right-sided valves. So is there any reason for that, since it's the same heart now? So are there reasons for the predilection for left-sided valves? That's actually my question.
Well, I think
Dr. Cassidy, can you hear us? Your line is breaking. Dr. Cassidy, can anyone else hear him?
I think we've lost him, or his network issues.
Yeah, so but Dr. Agu, if you know the answer, you can let us know. So that
Well, I don't know, maybe we'll say maybe because the right-sided valves, they are low pressure valves as compared to the left-sided valves, which have higher velocities. I don't know if that's the reason, but I think it could be the reason. I wanted to find out if there are other reasons, just to add and compare.
okay.
Hello, please can I?
Yes, you can, Dr. Okay.
Good morning, my teachers. Good morning, Dr. Cassidy. Thank you for your presentation. It was really good. I just want to answer the question the person talked about concerning how long are we going to give the patient prophylaxis. So it depends on the age of the patient, depend on if the patient is in an area where the patient can have recurrent infections, also depends on if there is carditis and if there is a persistent valve defect. So if the patient has rheumatic fever, has carditis, and has a persistent valvular defect, you're going to give the patient prophylaxis for 10 years or until the patient is 40 years? Which of them is longer? Like you take any of them that is longer. So you're going to give the patient prophylaxis 10 years or until the age of 40. Anyone that is longer is the one you would do. And then if the patient has rheumatic fever, has carditis, but does not have a persistent valvular lesion, you're going to give the patient prophylaxis for 10 years or until the patient is 21 years of age. So whichever is longer. Now, if the patient has only rheumatic fever, you're going to give the patient for 5 years or until the patient is 21 years of age. I don't know if it's clear, but that's how the prophylaxis should be given. Then concerning the valve, it's not like rheumatic heart disease cannot affect the right side, but it affects, we used to know it as MAT-P. So mitral valve is more, aortic valve, then tricuspid valve, and then rarely the pulmonary valves. And then another thing I want to say is that all patients that have valvular AF, warfarin, that's our vitamin K anticoagulant, is the anticoagulant of choice. And then the INR should be kept between 2 to 3. But if it's a patient that had rheumatic heart disease, had mitral stenosis, had valve replacement, then the INR will increase from 2.5 to 3.5. And then in the treatment of the patient, it also depends on the kind of valvular issue the patient had. I know he tried to differentiate it, mixed valve, aortic valve, and then the mitral valve. So depending on the type of valvular problem the patient has, that's what will inform your treatment. For example, if the patient has mitral stenosis, you won't want to use anything that would reduce the afterload. If not, the patient will go into hypotension. Unlike if the patient had other types of valvular issues. And then also, if the patient has mitral stenosis, if the patient does not have any contraindication, your first point of treatment would be, apart from medical, would be the PMC, that's percutaneous mitral commissurectomy or valvuloplasty. So thank you, Dr. Cassidy. I think it was a beautiful presentation.
Yeah, thank you, Dr. Eke, for a wonderful contribution. Even though Dr. Cassidy is not here, I think network probably had logged him off. So, Dr. Tanimu, you have any contribution? Yeah.
Yes, let's round off. The next speaker, please. Next speaker will.
Yes. Yes, ma'am. Dr. Tanimu, can you quickly make your contribution so that we can move?
Okay. Thank you very much. Thank you very much for this presentation. It was a good one. In addition to the prophylaxis, if patients have recurrence, even after 40 years, treatment for prophylaxis treatment with antibiotics can be for life. If there is still recurrence after 40 years of age, so the treatment can be even for life, for antibiotic prophylaxis. And it is not only benzosine penicillin, phenoxymethyl penicillin can also be used. Benzosine penicillin sometimes is restricted for poor, if patient is expected to have poor compliance. So monthly regimen for those that are poorly compliant. But sometimes the phenoxymethyl penicillin also can be used, but is taken BD drug, but more compliance is done in 10 when patient have is on monthly prophylaxis. About the etiopathogenesis supposed to have been mentioned even briefly about the causative agent and the etiopathogenesis is assumed to be molecular mimicry between M protein of the M protein of the cardiac myocyte and also the streptococcal antigen. So also there are some serogroups or serotypes associated with rheumatic fever. Serotypes of the group A beta hemolytic streptococcus, including serotype 3, 5, 6, 14, 18, 19, 24, 27, 29, are the serotypes associated with rheumatic fever. And also the mucoid type, serotype 18, is more of among them associated with rheumatic fever. More so also, rheumatic fever is part of the non-cirrhotic group A streptococcal sequelae of non-cirrhotic, including glomerulonephritis, So these non-sporadic diseases associated with streptococcus are about 5, including rheumatic heart disease, glomerulonephritis, PANDA, what they call pediatric autoimmune neurocognitive dysfunction associated with streptococcus, and also obsessive compulsive disorder and chorea. So those are the 5 among the non-sporadic group A streptococcus associated sequelae. So thank you very much. It's a very good presentation. Thank you very much. It's a nice.
Yeah, thank you, Dr. Tanimu, for your contribution. Let me quickly just read the messages from the inbox. Okay, Dr. Sawa said. Okay, he was referring to why the valves are affected. So he was talking about just re-emphasizing on the low pressure chambers. Healing tends to occur faster there. Is there any reason for oral contraception in the guidelines for pregnancy as against barrier or device methods? That's from Dr. Asekeme. I thought the contraceptives can also increase the risk of clot formation. Also, is it all valvular lesions that are treated with anticoagulation or only those with AF and transverse cause assessed? Then Dr. Rukaya said there are some guidelines that allow for lifelong antibiotics prophylaxis in high prevalence areas of recurrent acute rheumatic valvular heart disease. Well, Dr. Cassidy back. Okay, Dr. Agu, try sharing your screen while Dr. Cassidy. Did you get the questions I just read out?
Okay, sorry, I got some. My network is just.
Is there any reason for oral contraception?
You talk about why contraception. Okay.
Yes.
Well, because of the impact of pregnancy in patients with rheumatic heart disease, of course, which has a high mortality both for maternal and fetal cases. So we actually recommended that these patients should be advised and also informed about the complications. And then it's also they can be at least to prevent pregnancy. They were advised to be on contraception. So as in terms of both either barrier or oral contraception, I don't think there is actually any difference. So, but the patient can actually just to prevent pregnancy, especially in this patient, so that not to reduce the impact of these conditions in this group of patients.
And then he said the second valvular lesions, is all valvular lesions treated with anticoagulation or only those with AF and transverse access?
Well, mostly for patients that have, it has to be an indication for use of anticoagulations in this patient. So patient that has atrial fibrillations, so mostly we have to use anticoagulant at least to prevent, especially for stroke prevention. So I think mostly for people that have atrial fibrillation, except there are other indications where you have to use anticoagulant, especially based on your echo findings and all that. Like intracardiac thrombus, so because that patient has to be on anticoagulant.
Okay, thank you, Dr. Agu.
Oh, Chief, yeah, thank you, sir.
Yeah.
My question, I don't think I need slides. So it's counseling. I'm supposed to counsel a lady that came in. She did test.
Can you post the question?
I'm trying to look for the slide though, but I have the questions off head. I'm trying to look for the question. It's May 2023, number 2. I don't know if someone can assist to put it up. The first question is,
we need a simulator then. So we need.
Yeah, we need a simulator. I actually put it on the page. That's very early this morning. Now we need a simulator.
Let me try and see if I can share it. Can somebody simulate?
If you can share it.
So read out the question while I'm trying to look for it.
Okay. The first question is a young lady, she came in and did tests for herself, HIV test. You should tell her about the result of her investigation. That's the first one. Second one is, how do you break the news to the husband? She's married in a polygamous setting, about 5 wives. I think she's the first. So how do you break the news to the husband?
Okay.
Then the third question is,
I was thinking we
how do
repeated
you
this.
that's the question they gave me, May 2023. I don't know. My name was on number 2. So I
Hello,
worked on it.
can anyone? I thought we had already
Number 1.
treated this.
It's question 1. We'll answer that question. This question is question 1, not question 2.
Okay.
Oh,
Hmm.
Your question is question 1. So you attempt. We're done with. You attempted the discussion. So somebody should project
okay, the question 1.
question.
Just post the question 1 now. Let me look at it.
Okay.
I thought it was number 2, but I saw my name on number 2.
Okay. Let me check.
Okay, I see. Okay, I think I've seen it. Let me just put it on the page. Okay, I've put it on the page. I've seen it. I don't know if you can see it. The question, Jamison Recall 2023. Number 1 is, I can read it now, Chief.
Okay, yeah, just read.
Okay. A 45-year-old man with 1-year history of leg swelling, easy fatigability, and difficulty with breathing. Urea elevated, creatinine elevated, PCV was 15%. Has financial constraints. His ailment has affected him psychologically because of the likely cost of care. Mention the teams he would involve in his management and why. His cousin died of kidney disease 2 years ago. He's now depressed because he thinks he has the same disease. What teams would you involve at this stage and why? There was delay in initiating hemodialysis because patient declined as he was now anxious. What teams would you involve now and why? What investigations would you do in preparation for his hemodialysis? What is the definitive treatment? Would you enroll him in a cohort study? If yes or no, state the reasons for your answer. What are the poor predictors in patients with CKD? Okay, let me just attempt the questions now.
Okay, can go ahead.
Okay, so for the A, mention the teams you would involve in his management and why. Well, I would involve, I think this patient has some form of adult polycystic kidney disease, causing CKD. So I would want to involve the nephrologist who will be involved. And the reason is because the patient, from the history, I think the patient has CKD and might require urgent hemodialysis, as the case might be. So I would want to involve the nephrologist. I would also want to involve the hematologist. The hematologist will be involved in the management of this patient because the patient might be requiring some blood transfusions and all that. I would also want to involve the mental health department, the clinical psychologist, because obviously the patient is also depressed. He might need some degree of psychotherapy, and then of course the patient also has financial constraints. So I also want to involve the social workers, to see how we can raise money for this patient. And okay, it said for the second question B, his cousin died of kidney disease 2 years ago. He's now depressed because he thinks he has Thames disease. What teams would you involve at this stage and why? Well, I would also want to involve the nephrologist, of course, to take a look at the patient, assess the patient, do baseline investigations for the patient. I also want to involve the radiologist, this patient will benefit from investigations like renal scan, CT scan, and all that, so that to delineate if they're actually presence of the cysts in the kidney, quantified how many, and examine it and see if it's if it's infected and all that. I would also want to, there's also room for genetic screening in this kind of patients for their family lineage, to rule out the persons that might be at risk of developing these conditions. So I would also want to involve the genetics department to also assist in the assessment. Of course, the nephrology team would also want to maybe, after the assessment, and then, you put the patient on strict, advise the patient, counsel the patient, and all that. I would also want to bring in the clinical psychologist to also assist in ensuring the patient, has good, the patient is being counseled, and, of course, on what the condition is all about and reasons why he may not need to be worried as long as he's being managed appropriately. There's the question C, there was delay in initiating hemodialysis because patient declined and was now anxious. What teams would you involve now and why? I would also want to involve the clinical psychologist to really work on the patient. Of course, the clinical psychologist would want to counsel the patient, discuss with the patient, find out the patient's fears, worries, and of course, profile the patient with, information, knowledge on what is really going on and why the patient needs the dialysis, at least to prolong life, depending on when we can get access to the definitive management, which is renal transplant for this patient. So that's why I would want to involve them. What investigations would you do in preparation for hemodialysis? I'll do full blood count PCV. I also do have my baseline serum EU and creatinine. I also want to do retroviral screening. I want to do hepatitis B, hepatitis C screening for this patient. I think those are the investigations I want to do pre dialysis for this patient. Okay, the definitive treatment is a renal transplant, like I said. Would you enroll him in a cohort study? If yes or no, state the reasons for your answer. Well, I would want to involve him in a cohort study because I would want to, some of the studies that we have on adult polycystic kidney disease might come from the Western world. So if we have these patients with this kind of diagnosis, we might want to follow them up on the number of cysts, and of course the clinical presentations, the age presentation and all that. If we have data on our local data on the condition, it would also help, in improving management and then planning, of course, in follow-up with regards to this kind of cases. What are the poor predictors in patients with CKD? Well, I think increasing age of the patient is there. Serum creatinine and urea parameters are very high. Presence of comorbidities, like presence of heart failure, maybe, liver failure, presence of, some maybe cardiorenal syndrome in these patients, people that have baseline cardiac condition like valvular lesions, a patient that has diabetes mellitus, baseline diabetes mellitus, all these conditions, if they occur in presence of this could also worsen the prognosis for this kind of patients. And then also in the presence of sepsis, in a patient that has this kind of condition and presents with sepsis, it's usually very difficult to manage them. So these are just my submissions. I didn't know I was supposed to work on this number one question, so I actually worked on the number two. So I don't know if my chiefs, they can, furnish us with.
Thank you, Dr.
Thank you very much.
The class is open for contributions, please. Can we contribute to this discussion? You can type in the chat box or or you can raise your hand and speak. So, see, other prognostic factor is Dr. Ayodeji. See, other prognostic factor is berry aneurysm in the brain and hepatic cyst. Any other contribution? Okay, Dr. Chidima.
Okay.
Dr. Chidima.
Good morning, my teachers and colleagues. Please, I just want to find out, as in the last question, were they talking about what are the predictors of CKD, like poor predictors of CKD in this particular patient, or they are talking about CKD in general? Because what I'm saying here is, what are the poor predictors in patients with CKD? So, I don't know. And of course, yes. Can you hear me, sir?
Yes, we can hear you. I think it's...
Yes, sir. Yes, sir. I think I just took the question literally the way it was written. What are the poor predictors in CKD, but not necessarily in these patients, you know?
Okay. So I just wanted to add a few things, like, of course, like you spoke about increasing age, patients who, male patients with anemia, if there's, like you said, comorbidities, hypertension, diabetes, patients that have, where there's a cardiovascular disease, and if there's a family history of kidney disease in the patients. Yeah, I think that's what I can contribute. Then another issue is the C. I think it's to find out the reason why the patient declined hemodialysis in the first place. Because if the cousin died of kidney disease 2 years ago, was it as a result of maybe the patient was on hemodialysis and in the process the cousin died? Because I know that I've had the patients who had a similar thing, had a brother, someone that had polycystic kidney disease, and had a brother that died of the same end-stage kidney disease, but it was while the patient was still on hemodialysis. So at the end of the day, he didn't even want to go for dialysis. Instead, he actually opted for going for the kidney transplant first. That's to go for the kidney transplant instead. But the thing about it was that he already had high urea and creatinine levels. So obviously he had to do some sessions of hemodialysis before going for the transplant. So we had to get in the, like you said, the psychologist and the nephrologist to explain to him why he needed to have the hemodialysis first. And of course, you would have to explain the complications of the complications he might have as a result of the hemodialysis before, so he would be aware. But you have to make him know that the hemodialysis is very, very important even before he goes for the renal transplant. Then, of course, having a genetic counselor is important, because the genetic counselor will be able to get his other relatives and screen them for polycystic kidney disease. And also sorry, I'm talking haphazardly. And also the need for him doing like an ultrasound scan is important, because it's not only in the kidneys that you can tend to have disease. The liver also can have the cyst. Also, the pancreas can have the cyst. And not only there, they also have other organ involvement. The heart, they tend to, in the cardiovascular area, they tend to have thoracic, they can have thoracic aneurysms. Also within the heart, they can have valvular, I think mitral, I'm not really sure. I think mitral valvular diseases, yes, but I'm not sure whether it's stenosis or regurgitation. And they can also have coronary artery aneurysms there. So the need for an echo is very, very important in such patients. Then, of course, it's not every patient with polycystic kidney disease that should be screened, that should have a cerebral, like an MRI to check for aneurysms. There are some certain things that would make you want to have make you want to do the screening. So if the patient has had a history of any relative that has had like an aneurysm or had a ruptured aneurysm, or if the patient has had a ruptured aneurysm in the past, or if the patient has gone through any recent surgeries. I can't really remember the rest. Thank you very much. Thank you.
Okay, thank you very much, Dr. Chidima. Dr. Fatima, you go ahead.
Good morning, all participants. Just to call the attention of the person that attempted and you, Dr. Chidima, if you look at this question, nobody is like you are trying to set another question for yourself. You are all talking of ADPKD. This patient, they just said he has CKD, and later telling us that a cousin had similar kidney disease. Is it that you mean ADPKD is the only kidney disease that will run in the family? You are supposed to answer this question in line with CKD. No one asks you what exactly is the diagnosis. So don't commit yourself to going down to ADPKD. You are just supposed to answer this question as per CKD, but not turning it to ADPKD. Yeah, that's my contribution.
Thank you very much, Ma. That's why I raised the question in number, the last question, because what I noticed there was predictors of CKD. So that's why I wanted to clarify initially before.
Those are predictors of poor outcome in all patients with CKD, not only ADPKD, predictors of poor outcome in any patient with CKD.
Yeah, thank you.
Thank you, Ma. Thank you, Ma, for the recommendation. Thank you.
Okay. Okay, Dr. Tanim will say the socioeconomic status may also be a poor prognostic factor, as exemplified in the patient. Dr. Ukam says smoking, dyslipidemia, genetic predisposition, hyperuricemia, nephrotoxin, recurrent AKI events, obesity, metabolic syndrome, poor BP control. All of this poor predictor of prognosis in CKD patients. Is there any other contribution? Our time is fast spent.
Dr. Atta.
Yes, ma'am.
Dr. Atta, I'm about to call in.
Hello, ma'am. Hello, ma'am.
It seems our network is fluctuating. She's talking, but we can't hear her.
Yeah. I think she's left the class. So over to our teachers, Dr. Shitu, sir. Good morning, sir.
Good morning, Dr. Atta. Good morning, everyone. Dr. Christabel and all the speakers. Everybody at SIMTA has spoken well. I think I wanted to add some other predictors of poor prognosis, but I think somebody added it from the chat room. Obesity, smoking, a low socioeconomic group, and of course, recurrent AKIs. Those are important things to add. I think for the group of people that you need to put together to deal with this patient that may need dialysis, okay, it's important that you involve the nephrology nurses, of course, the technicians involved in ensuring hemodialysis. Okay, it's also good to also involve clinical psychologists and the behavioral scientists or the psychiatrists, whatever you want to call. Okay, so it's important you add all those people into the mix. Then you do not leave out the people involved in helping you make your investigations stick. So the chem pathologists and of course the radiologists, particularly if you are suspecting something structural in the end. Okay, so all those people have to be involved in the management of the patient. So you need to think far and wide about everybody that the patient should come in contact with at every point in time, okay, to ensure the smooth management of the patient. Then also, if the cause of the chronic kidney disease can't be determined, that is also a poor prognostic factor. So I think the speakers have done well. With done justice to the question. Thank you, Dr. Atta.
Thank you very much, sir. Thank you very much, sir. Dr. Christopher, you're back.
Thank you very much, sir. Thank you, sir.
Dr. Christopher. I think she still has a network issue. So I'll come back to you, sir.
Dr. Atta.
Okay.
Dr. Atta, I'm here.
Okay, all right.
Dr. Atta, how are you?
Fine, we can hear you, ma'am.
Oh, sorry. Chief Chitu, sir, thank you so much. Thank you for running down up. Dr. Atta, thank you. Thank you. Dr. Atta, I don't think I missed anything. I was multitasking. Hope there's no other issue.
No, ma'am. No.
Okay, thank you so much. I must appreciate the two speakers today. The first speaker, Dr. Pide Kakidi. I think he has to be speaking more often. He was moving a lot of stuff, but you have been very quiet in the class. But I know he joined recently, so I'm really impressed. Please, we want to be hearing your voice. Dr. Chineme, once again, thank you for always coming to our rescue. My dear Chief, Dr. Ifere, thank you so much. And Dr. Agu, thank you. I know it was spot on. It wasn't a question you prepared for. But thank you, it was a fair attempt. And Chief Chitu, thank you, sir. Dr. Fatima, thank you. I want to thank everyone for coming to class. It's past 8 already. I have to call it a day. Everyone have a nice day. We'll meet again tomorrow. Thank you. Otata, thank you so much.
Thank you, ma. Bye.
Thank you, ma. All right, everyone.
Thank you, ma. Thank you, ma.